Dear colleagues, good morning. So we are waiting for some other participants to join, and now we'll talk about some technical details of the webinar and how you can profit from PASTE activities. So PASTE is the British foundation that promotes palliative care via education. I do hope that you've already participated in our webinars that take place monthly. We cover different topics, starting with the organization of palliative care. We also talk about some medical aspects. In November and December, we won't be touching upon the medical aspects that much. I would like to thank our colleagues from other countries, Georgia, Belarus, Kazakhstan, and many other countries. And if you do have any initiatives, if you would like to share your expertise, then we would be happy to also give you the floor, because we would like to make PASTE not only the organization that shares information from the UK, Europe, and other countries, but we'll also like to get experience from other countries. So some good news. To make it easier for you to initiate some educational activities, we have a grant program launched by PASTE. We will publish the announcement, but I would just like to talk about this now a little bit. If you would like to organize any educational events in palliative care, if you'd like to exchange experience and organize some internships, then PASTE grant program is there to help you. Recently, we organized an educational day on difficult topics in palliative care. And I would like to thank Julia from Latvia for the invitation. And the recordings will be published on our channel. What's also important is that all the webinars that we organize offer simultaneous interpretation. So if it's more comfortable for you to listen in English, you have a special globe button at the bottom of your screen, and then you'll be able to listen to our event in English. So all our events are bilingual. And if we have colleagues speaking English, then we can also interpret colleagues into different languages. For example, we had such an event with Georgian language already. So also, please do not forget about our newsletters, monthly ones. And you can subscribe to these newsletters on our website. So I think it's time for us to officially start, and it's my pleasure to introduce our speaker for today, Nuta Federmesser. She's not only the founder of VERA Foundation, she's also the driving force of palliative care in Russia, and she's also one of the co-founders of PASTE Foundation. So that's our great pleasure to welcome Nuta today. And Nuta won't be our only speaker today, but she'll be powerfully supported by Anastasia Zhdanova. She is a lawyer, and she works with the legislative changes in the field of palliative care and medicines. And I'm very happy that with every webinar, we expand the expertise of our speakers, because we had some events on Kazakhstan, Belarus, and other countries, and we welcomed doctors, nurses, rehabilitologists, etc., and many other areas, because these are actually the areas that make palliative care possible. And lawyers are also professionals that help palliative care, especially when the legislation is far from being perfect and there is still a lot of room for development. So today we have this wonderful team of Nuta and Anastasia. And so just in case, if you'd like to learn more about the classification from the Worldwide Palliative Care Alliance, then we will also post the links in the chat, and you'll be able to see the classification of the countries. And so now it's my pleasure to give the floor to my colleagues, to Nuta and Anastasia. Good morning. First and foremost, I'm sorry for my voice. And I have a question to the organizers of this event. Do you already know how many people are listening to us now and watching, and from what countries? Because it will help me to cater to their needs. Right, I can ask Irina probably to help, right? Yes, I can add. We definitely have professionals from Israel, from Moldova, from Armenia, from Russia, from Belarus. So we are sure that we have participants from these countries and other ones as well. Now we have 19 participants that they continue to join us. Okay, thanks a lot. Then let's probably share my slides. Right, so we're sharing the screen. Can you see my slides? Right, we can. Okay, so today we will spend about 2 hours together, and we will talk about our slides together with my colleague Nastya. And so we have people from Israel, and I'm sure that those are not only our employees, but also just participants. I stand with you regardless of my Jewish origin, but also taking that into account, and we will win in the nearest future. So I think that the world has gone crazy completely because the speed of going into the abyss is just, we can't even feel it anymore. The speed is so immense that I can't actually even feel the speed anymore. That means that it's too high. And the only thing that we have left from the humanity, I think, is the palliative care. So that's the only thing that unites us. And the only thing we can do, and we can do it professionally, is to distinguish between the end of life in dignity and end of life in no dignity. And I think that palliative care is the only anchor that we can use, that we can hang to when it comes to some human values. We need to provide a person with the opportunity to end their life in dignity with their families, to have time to say goodbyes, to forgive their families, to be forgiven by their families. So they need to have this time. And so we need to strive at this. And in our work, we mm, or by our work, we educate millions of crazy people around us. So let's start. When we were getting ready for this webinar together with Nastya, Nastya has a very logical, legal mindset, and she divided the development of palliative care in Russia in 4 stages. And those 4 stages of the development of palliative care in Russia are corresponding to actually the levels that we can see in the World Atlas of the Worldwide Palliative Care. So Nastya will comment on that. Right. So the first hospices appeared in Russia in 1990s as separate centers. Those appeared in St. Petersburg, Moscow, the Tula region, and Ulyanovskaya region. And so hospices were not included to the healthcare system. The population didn't know about the palliative care. The medical staff didn't know about palliative care. And so we have this difference between primary care and hospices. And usually people learned about it just without any intent. And in the clinics, in hospitals, nobody is actually forwarding patients to the hospices. This is what we call level 2, according to our categorization. And so that is the level that unfortunately is the level of palliative care in Kyrgyzstan, in Kazakhstan, in Tajikistan, and unfortunately maybe in Georgia and Armenia as well. Well, Kazakhstan has moved a bit forward in this respect already, as far as I know. So here you can see the first hospices. Right, so I think that we will talk about it a bit later as well. So the first period, the first stage for us are the separate centers of care. Those are only due to the efforts of enthusiastic people, those who, with their power, with their character, were convinced that they were doing the right thing and they were trying to literally break the walls. And here, the unified format of the hospice palliative care, um, that's actually the way Canada, the UK, as well as some African countries have gone through. So this is very typical approach when everything starts with some enthusiastic effort. And with the dissolution of the USSR in the 90s, this initiative actually came to surface when we started to notice the person. We started to learn to notice the person. And in 2000s, in the first decade of the 2000s, when people learned about this care, those rare practices started to multiply. And so, since they started to multiply, we had to actually somehow recognize it legally. And so the same happened in Belarus, but a bit earlier. And well, I think I was wrong when I said that Kazakhstan at the level 2. I think that now Kazakhstan is already at the next level. So the third level here that we can see on the screen as well, it's 3B according to the worldwide classification. And the peak of that development happened or happens, better to say, when the government recognizes the necessity to establish the legal framework, when the state recognizes the necessity of the involvement of non-profit, non-governmental organizations, when the topic becomes very relevant for the media outlets. And the fourth stage, in Russia, this stage started in the last year before COVID-19, that means year 2019. And this stage continues, and we don't know for how long it will continue, maybe for another dozen of years, because even internally in Russia, we have very uneven palliative care. Legislative framework is the same, and it's interesting because it's quite a unique case. When the legislation is the same, at the legislative level, everything is created, but at the level of infrastructure, some Russian regions are on this first level. So some Russian regions are still stuck in the 1990s. And so this is our first hospice in St. Petersburg. This is the way it looks now, but it actually was very different in the past. Andrei Gnezdilov founded this small house in Lakhta. This is a hospice in Tula region. Elmira Karajayeva, the founder of this hospice, died quite some time ago, and I do hope that this hospice will take her name. This is the first Moscow hospice named after Vera Milyonchikova, established by Viktor Zorze, and it appeared in 1994. So the pioneers of adult palliative care are VERA and Galina Chalkova is the pioneer in the field of pediatric palliative care. And with a difference of about 1 year, they also died in that hospice. So the second stage, a lot has happened when those separate centers started to multiply, and by the word of mouth, the information is distributed. And so here you can see this timeline. In 1994, the first Moscow hospice was established, and for a long time it was the only one, and then initiated by Vera Milyonshikova. By 2000, we got 8 hospices in Moscow, but those were like 8 buildings. That doesn't mean that, well, we were following the philosophy of palliative care. And so we are also connecting from the first Moscow hospice today, and it was supported by charity, but there was no foundation. There was no organization that was supporting it. So it was an anonymous aid and anonymous care, and it wasn't somehow publicized. And the foundation actually appeared in 2006, and it got the name after Vera Milyonshikova. And initially, it was created to actually support this first Moscow hospice. And I always want to refer to those who are listening to us today, because the foundations have to be created and taking into account the experience of other countries. It's good to create foundations near the organizations. It doesn't necessarily mean that we have to have one foundation that will help everybody. The more foundations we have, the better. It will free you. If a non-commercial organization is established, and then it helps each of the palliative care organizations, because that's how one gets more financial freedom and freedom in general. Then, 2007, we started to help other hospices in Moscow because we wanted to at least have one city where the hospices were standardized when it comes to the services they were providing. In 2008, when Russia was a relatively free country and the legislation was developing, not getting worse, we've got a law on endowment. And we created one. In Russian, we call it a targeted capital. So in English, it's once again endowment fund. And that endowment, I think, still is the only one in the field of healthcare, because we've got some in the field of culture and education, but in the field of healthcare, this is, I think, still the only one. And also, we started the information campaign, the raising awareness campaign within the country, because we started to talk about hospices, what they are actually. One of the British hospices had a slogan, and so somehow we got the inspiration from that slogan, and we came up with the slogan that if a person can't be cured, it doesn't mean that.
Сознание и пациента, и медицинского сообщества. Вообще, мне кажется, что самое главное,
And it changed a lot.
мне правда так кажется, особенно в условиях войны
And
и
so I
бушующей,
think it's very important,
самое главное
especially in the context of war. So the word is a very important one,
найти нужные слова, то
because if you find
ситуация начнет меняться. И в
good
зависимости от
words,
того,
that
какие
situation will
слова
start to change. And depending on what words you choose, the situation will also change accordingly. So in 2009, the VERA Foundation started to help hospices in other regions. In 2010, unfortunately, my mother, Vera, died, and it gave the impetus to the fundraising.
In 2011, we started working on the first international conference. Robert Twyckas attended it, one of the founders of palliative care across the world, one of the founders of PASTE. PASTE is, in many senses, his brainchild, palliative care education. He was speaking to us fantastically. He addressed the Ministry of Health of the Russian Federation. He said, it was very emotional, you know. Many of you might have seen him. He's tall, there, gray hair, I would say eccentric, all gentleman. I said, who tells that more thinking kills? The absence of more thinking kills people. This was the explosive effect. What do you mean the morphine lack that kills people? At the very same year, in Russia, we've had this new law protecting healthcare facilities. There was this palliative care term used, and this was used without any participation of palliative care professionals. The definition that was given there was the contrary of palliative care, was the contrary to the palliative care of the World Health Care Organization. In this document, they said that palliative care was all about medical interventions and medical procedures. And in this sense, it caters into the wrong understanding of professional, specialized medical palliative care. Of course, the enthusiasts of non-commercial organizations the very next year have launched a project to create a kids hospice. And there's a huge team of professionals. They go to study in Poland and in the UK. Next year, we're given a building for the kids hospice, and the adult hospice where we are right now starts receiving kids officially and receives them throughout many years, up to the point until the doors of the kids hospice open. The charity fund VERA, understanding that in Moscow we may already have kids palliative care, and in region it's impossible, we started helping families at home. 2014 looked very much like what's happening in Georgia and Armenia and Kazakhstan and Kyrgyzstan. It's very much alike. Oh, I'm sorry it's taken so long if you follow this timeline. But in 2015, also was the participation of Robert Twyckas, who is a fantastic enthusiast and a great professional. We managed to convince the healthcare ministry that we should create the association of hospice professionals. In Kazakhstan, the organization like that was created earlier, actually, which is interesting. VERA Fund starts the project of the hotline, and we have also launched Pro-Palliative. It's a resource I'm sure you all know about. Pro-Palliative is an educational resource. I hope that PASTE has also a similar resource. To me, it's the best that exists in the web in terms of our topic. Later, 2016, we have made a decision so that palliative care no longer depends on every specific person heading this or that hospice, in order to not have those counter-directed forces pulling people into different directions, so that it's all an orchestra of standards, an orchestra of efforts. In order to follow global standards, we have united all the hospices in one specific center, because when you have one head and one leader, it's easier, everything's easier. It's easier to control things, it's easier to achieve one standardized format in procurement, in pain relief, in prepping nurses. I've become this director, but back at that time, and I understood, in the strategy, I also understand that. In terms of finalizing the standardization, all hospices should leave the state service providers, and the state should only do quality control and funding, but the service provision should be all done by non-state-based or non-government-based providers. Politics and legal issues, of course, change our intentions, but the path and the direction, I would say, it's still in place. Even now, in 2023, we are... I'm sorry for the little noise. We have... Oh, yeah, I'm not going to do that anymore. No worries. It's nice to see your hearts. Oh, me too. Thank you so much. I love you. Yes, thank you. Oh, please stop. It's actually destructive. Okay. So it's very necessary to introduce non-state service providers, and the state should only do control, streamlining, steering, etc. A part of our structure will go under the healthcare department of Moscow. There we'll have the control of gearing and steering for this palliative care centers in Moscow. A lot may be said about legal issues and legal changes, as well as local issues that perhaps you want to observe later. What kind of beds are open? What kind of projects are open? The only thing that is important now is that system development goes along with the charity sector in general. VERA is not shrinking, it's actually growing the level of activities. A couple of years ago, we could say that VERA is the only fund in this huge Russian Federation that's dealing with the development of palliative care. Right now, VERA has the support program for the regional funds, local funds. We have more than 60 organizations, 60 organizations like that across the country. These is not competition, of course not, far from that. It's far from that, really. It's still the development of the market. It's finally the understanding of the regions. The funds in the regions appear, they grow, and we understand that more and more regions transition from level 2 to level 3A, to the second level. Moscow, at the same time, we should correct this. I'm sorry. In 2024, this launch of telematic services, it will be done only in Moscow, unfortunately. Yes, we want to do that, do the consults online. The first consultancies, I was pretty shocked to see them. This happened first in 2017 that I've seen this in Warsaw. The kids' hospice used and utilized these telematic consultations. And 2025, infrastructure-wise, Moscow should stop building up the system. Okay, in more detail, we should speak about the third level of development. This implies a lot of legal changes. This is something that drags behind the health development in multiple countries where you join from. This is your main headache, I would say. But before we move on to this third stage, what I should say, this legal base does not influence the quality of services provided. Their service in certain places was very high quality before the law appeared, and it's still high quality. Of course, not everywhere, but in the places where you have interested, engaged, curious people. The legal base gives you an opportunity, but it doesn't guarantee anything. And here, I think, can I say a few words about this slide? Yes, we speak here that we have this third stage. This is the stage when the biggest and the brightest changes happen. This was the summit of the development all across Russia when we've united all the efforts of the government, of the business community, of media, of the NGOs. We had a certain unity. On the one hand, we have received the support both from the fund of VERA. We also had the government support on all levels, from regional level, where Mr. Pechatnikov offered Nuta to head the Center of Palliative Care, asking her a question that we should move towards a new level probably, not only criticize, but you should do it on your own, yourself. This was the unification of efforts. When the government approached the NGO and they said, please, you know how to do it better, please do it. We have received the support from the federal level. In a sense, we had some direct contacts with the Ministry of Health, or with the government of the Russian Federation, and even with the top level in the government of the country, when we understood that we can move the changes and improve and advance the legal base. We'll tell you later how it works. I cannot answer the question why it happened, but I can answer the question how it happened, how we were moving in this direction. And what's important, you know, perhaps, I'm sure you know, this book, Derek Doyle, I think it's called How to Start. Yeah, about palliative care, where he's describing these periods and development stages. And this third level, 3A level, where many of you are at the moment, it's inevitable. It's also inevitable. It's absolutely a must, and it should introduce all the 4 components. You will not be able to move forward without putting together the government, NGO, business, and media. Basically, the whole society, because the media creates the direct request from the society towards the quality of support. And when we were at this third stage of development, first of all, we faced, of course, some specificities of our country, of Russia. We had some very typical problems, obviously, which every country meets in the development of palliative care. However, we also needed to take into account the specificities of the Russian Federation, and we'll speak about that in a moment. It's a very complex and perhaps the biggest challenge. And in my personal opinion, because of this challenge, we have pace that appeared, and we had this right, I would say, to approach the representatives of other countries. Look, we've changed the definition of palliative care in our law. We made it more sensible, more relevant to the global understanding, to WHO understanding. We've convinced the government leaders to change the legal base for pain relief. We have understood that hospice is a type of a medical organization, and that's what it should be defined. That we also convinced that there should be a specialization called palliative care doctor. And then came the question, how do we implement the law that was signed in the center of multi-million Moscow by the people who have not seen what the life looks like beyond a great megapolis. How do we try to convince people in different regions? Okay, 8 hospices in Moscow. And how about Yakutia? How about Tiva? How about Dagestan? I'm scared to speak about that after last night, to pronounce this republic. But anyway, how about the Caucasus, where the mentality and the mindset is so different, and where assistance to elderly people anthropologically, culture-wise, is done at home. And it's very interesting, you know, if in Moscow we try to prove and convince that in our institution the relatives should have access 24/7, in the Caucasus there is no problem like that. If you try not to allow relatives in, the relatives will just destroy the hospital. The question is how many can be allowed inside at the moment. One of the hospitals in Makhachkala, I think, yes, they said we try not to allow into the operation room no more than 4 people, because it's hard to add 4, and more. It's hard to work when you have such a crowd inside the operation room. So the territory is so diverse. The economic situation is so diverse. There may be no toilet in the building. There may be no central heating. It's also very doable in some medical institutions. There are some medical institutions in the country that have no central heating, that are covered with snow in the wintertime, and that have poor transportation access. Cultural differences are so serious for Muslim regions, for Buddhist areas, for Christian areas. There are so many different of them. For Muslim regions in the Caucasus, under the auspices of mosques, we have the nursing courses. So spreading information, knowledge, and the culture of support should be done through madrasa, through mosque schools, non-secular medical institutions, non-secular medical colleges. It works faster and better than through secular state-based institutions. We have a fantastic doctor of economics, Professor Zubarevich. Many years ago, she has introduced the theory of 4 Russias. The first ones are the city megapolises, Moscow, St. Petersburg, Yekaterinburg, Novosibirsk, and other areas that are very modernized and advanced economically, very developed territories. The second Russia are second-tier cities, such as Nizhny Novgorod, for example, or, for instance, Kaluga, or what else? They are the cities 500,000 to 1 million residents, I would say, yes. The third Russia are smaller cities and towns, some of the settlements in the rural areas. It's the biggest territory of Russia, I would say. This is the province, the so-called peripheric Russia, when it comes to the quality of socio-economic life. This is Russia with the prevalence of elderly people, where younger people are drained away, where you have high alcoholic addiction, and of course its own specificity. And it's the majority of the country. And the fourth Russia are the so-called ethnic republics in the Caucasus, south of Siberia. This is also a locality, but with its own, I would say, characteristic feature. There are certain religious specificities that urbanization and the transition of people to the cities is still a non-completed process. It's still ongoing, and it's a very strongly patriarchal territory. So the support is very much requested for the hospice care, and it's so hard to compare it to something that happened after the Second World War in the UK, because this is what our role model is. It's quite impossible to compare. So the same kind of pieces, it can hardly be called a country, but the same kind of territory pieces may be found in Armenia and Tajikistan, in many other places. There are also segments of territories which should be approached very differently, with a very different type of measurement. With such different territories, the factors that go down in terms of the accessibility, they're all very united. These are the factors that do not give us a chance to reach the level for A or for B. The main one is that the national strategies in the countries doesn't include the strategy of palliative care.
Or maybe there's a limited opportunity actually to train doctors in palliative care, or it doesn't exist at all. For example, the majority of the European countries has about 30 majors in palliative care. It's not positions, but those are specialties, majors. So in these 30 specialties, there is a doctor in palliative care. So this is the postgraduate education in Europe. And in Russia, there are 94 medical professions. And there is no such a profession as the palliative care doctor, even though we've got already trainings in that. And it's important to see the dynamic. How should it be organized? First, training courses, then the profession, and after that, professional education. So the profession can actually appear when there is enough practice that already exists. So another factor that what actually influences us, and it's very important. If there was a strategy, it would be easier. So it's good for countries to start with a strategy. So the third factor are the normative limitations, legislative limitations when it comes to morphine and similar medicines. Fourth factor here is the accessibility to and availability of opioid analgesics. Fifth factor here, the absence of information among civil servants, medical professionals, and patients. If we don't know that something exists, we can't want it. If people know that cancer is associated with suffering, pain, and there is no way out of it, then patients and people don't require anything, they don't demand anything. And that's why the government doesn't respond to this absent demand. Well, the governmental bodies are never proactive when it comes to human things. And sixth factor are social and cultural barriers, and the seventh limitation here is the stigma around palliative care. That's what we are fighting in Russia, and also I see this happening in many countries of the world. Hospices, especially for those people who never went there, they're associated not with life, but rather with death. But those people who somehow saw hospices in their life, they do understand that hospice, it's not about death, it's about life as it is. So all these factors decrease the availability of palliative care. Only about 14% of people in the world that need palliative care actually get it. So out of everybody, only 14% get palliative care among those who need it really. So how one can change it? I would like to also add a little bit, and we'll get back to the previous slide. So we were actually working over our third stage of development of palliative care in Russia. We were working with all these factors that limit the access to the palliative care in Russia. And so in that situation, we had to unite all the resources. First, political will, which should help us to change the situation. Also, the availability of analgesics, as well as training of professionals and creation of infrastructure. So we touched upon all of this. And one of the priority tasks for us at that stage was to explain to the authorities what we want. We had to communicate in a systematic manner what we need to make the palliative care available. We saw that not in the national healthcare project, not in the demographic national project, there was no word on palliative care, because for the state it's important to increase the birth rates, also to treat the diseases that can kill people. So basically, the state needs healthy taxpayers. But the palliative care is about something different. It doesn't provide any economic effect. At least the state doesn't see this economic effect in a transparent manner. Because it does exist, but it's not that visible, it's not that transparent. So we had to interest the authorities in palliative care. So we had to push through the mass media. We had to tell some stories, some real stories, to get the attention from the society, and that would result in the attention from the government. And secondly, we had to explain to the government why it is actually economically efficient. But I think I would like to now show you a short video about that priority project. And so to actually come to that priority project, we already had to do a lot in advance, because we had to get to some level of interaction with the authorities. At the same time, this video that we are going to show you, it takes us to this new level of our interaction with the governmental bodies. So we will watch it first, and then we will discuss it, because it's like a course book. It's very telling. So we will stop the sharing option of the presentation. And Ksenia, could you please start the video?
Вам нужно на красную кнопку нажать, отключить
Остановить.
Вот, супер, все сработало, включай.
Right, now we have the opportunity to start the video. Why the development of palliative care in Russia should become the priority project. In accordance with the Federal Law 323, palliative medical care is the set of medical interventions that are aimed at preventing pain and easing some other conditions for those patients that are incurable. The comprehensive medical care to incurable patients and their families is one of the very important indicators of a life standard, and that adds to the well-being of a region and the country as it is. And so it's in the countries in this interest to help those who can't be cured, let alone helping those people that can be cured without pain, but with gratitude. So the priority project increasing the quality and accessibility of palliative care in Russia. Palliative care is the least expensive method because it doesn't have any diagnostics and very expensive medicine. It's just symptom management. pain relief and care. And about 70% of people who died needed that. But at the same time, only 15% in Russia get this aid. So the inaccessibility of analgesics, also unavailability of palliative care at home. There are no standards and protocols for incurable patients, and lack in the palliative care professionals. Those are the main problems in Russia in palliative care. According to the world standards, for the town of 300,000, 400,000 people, there should be at least one hospice. And there is no region in Russia that actually satisfies this demand. In 2016, 1.3 million people in Russia needed palliative care. In fact, there are even much more because they also have families, friends, and this figure grew up to the 18 million people. Up until now in Russia, nobody seen these people as the palliative care receivers. According to the WHO, palliative care, it's not only about patients, it's also about their families, dear ones, because families also experience grief and some other problems. And palliative care should take care of this. The priority project is the plan of specific steps that will change the situation and will allow to build an efficient palliative care system. We have such aspects as the organization of the care, the training and staff, medicines, etc. By 2025, we will get more analgesics, 20 times more. And we also will increase the number of medical professionals. You can see this growth now. The growth will be more than by 2.5 times. We'll also raise awareness among medical staff about palliative care. One of the very important conditions for palliative care is the changes in the Russian legislation. The creation of inter-body system of medical services in the field of palliative care will increase the number of patients that can get it. One of the indicators of the change is the upgraded rating of Russia in the World Atlas from the level 3A up to the level 4B. These are the countries where palliative care is integrated in the healthcare system. So priority project is about optimization of the budget, of the spendings of the government, because artificial lung ventilation at home is 4.4 times less expensive than in a hospital. And even here, we can save up to 36 billion rubles per year. And also when there is no need for ambulance and taking palliative patients in hospital, when we can save up to 126 billion rubles per year. And about 265 billion rubles is lost because of the decreased activity of families of palliative patients. In 2018, we identified the list of medicines that are not circulating in the Russian pharma market that are needed for palliative care. Then we also regulated the palliative care standards where patients actually live. We also eased the access of children to analgesics through the shortened period of medicines expertise. In 2019, hundreds of patients that need artificial lung ventilation at home get this care. We also launched the Federal Info Platform for speedy information distribution for palliative care, in palliative care, and pain relief for palliative patients. In 2020, volunteering and non-commercial organizations provide palliative care in all the regions of Russia. In 5 regions, we opened resource centers to implement the typical models for palliative care locally. Efficient palliative care system, as well as the raised awareness among society. It's not only about high quality of life for millions of people, but it's also economic benefit for the state, and it's about the support of the economic policy of the state from the third sector. In the result, we will get 18 million of people that are thankful to the state and not angry at the state. That's why it's very important to prioritize palliative care in Russia, not only at the federal level, but locally, especially locally. We do not forget about aid and help in grief. Okay, so now we will discuss what we've seen. So now we'll discuss the slides in details. Now you should be able to see my screen and the actual slides that we've seen in the video. Yes, everything is working. Well, first, it's important to understand that any country, any state has its priorities. It has its own schemes how to work in some particular areas, such as national programs. For example, this is the national program for economy, for the defense, or for industry, etc. And we also have national program for healthcare and social protection. And before speaking about national strategy, one needs to learn the priorities of the state that are already being implemented. For example, in Russia, at that time, we had a trend for national projects. And we had national projects in multiple areas. National projects were the part of a national strategy. And that is an element of any country management. So, actually, you don't need to meet anybody, to talk to anybody, to understand the current national policy, national strategy. You just need to read the documents to understand the goals in the field of social security and protection and medicine, healthcare. You just need to read the documents. And there'll definitely be some concepts on family, long life, the quality of life, etc. And when you see some elements that are related to your field, well, just to make it more clear, nobody says anything about palliative care in any national strategy, but a lot of countries actually say a lot about long life importance as well as the quality of life of elderly people. And this is your anchor because the medicine is developing, people started to live longer. If they started to live longer, that means that the period of chronic diseases and end of life is also longer. That's why palliative care should be developed. So this is your starting point. And we managed to do this because we understood two things. First, we understood that we have to get a priority project and we need to be included into the healthcare national project. Secondly, we realized that Russia wanted to develop its technologies. And the key factor for us was the production of opioid analgesics. So up until we were just shouting that people die in pain, nobody listened to us, nobody heard us. But when we started to say that, to provide the pain relief for the population that needs it, you need to produce this amount of analgesics on those industrial capacities, and that will produce this amount of money, we were heard because this is a production market. So that is the angle from which we started. Now let's review the presentation in details.
Они не хотят двигать нас вправо-влево.
We are experiencing some problems with a slide
Сейчас,
change.
подождите.
Sorry?
Куда-то же мы нажмем. Может быть, да, стоп. Точно.
Right, now it works. Sorry.
Значит, чиновники привыкли
So, civil servants
к сухим докладам и к
are accustomed to reports, very dry reports and presentation with a lot of figures. On the one hand, you have to speak with the civil servants in their own language. At the same time, you need to kind of surprise them. You need to actually be significant. And what we've done. In this priority project, we've compiled a presentation. So we've added figures, we've added slides and graphs, but we also made a video with a voice, and we used a number of psychological components.
This is what it's customary for the authorities. That's how we've highlighted the document. This is something that they also get used to, some kind of a graph, the infographics, that this is not efficient as a solution. Any authority member wants to be efficient, so if they want it all to be red, they need to move somewhere. Then we try to show that we have already identified the problem. You don't need to search for the problem. We've done that for you. These are the 4 problems that we've identified. And we try to show them that they're not efficient as leaders. This is all pretty offensive and painful to them. But if you remember, the voice is quite, energetic, and this voice doesn't let them feel offended or something, I'd put it this way. Next is we've identified this beautiful thing. It works in any country across the world. You probably understand that a cynical politician is not interested in a dying patient. A dying patient is not a voter. A voter is someone who stays alive after they are gone. This is what they are triggered by. You don't need this 1.3 million patients, but you know someone who stays alive. Then these people are either angry or thankful. Thankful people will support the system. This is because the system has supported them in the most painful period of their life. This is 15% of the Russian population, these 18 million people, and there are many new people coming every year. So this is an updated community of people. And when we say friends, family, colleagues, and neighbors, these are not just random people, these are the voters. Next, it was 2017. Russia, back at that time, it was quite important for it to be a part of the international community and to, try to be somehow positive. We were trying to compare the definition, the wrong one, the complex of medical interventions. And we compared this with the one from World Health Organization, the approach that defines the quality of life of patients and their families. It's not just our fantasy that the family is important. It's the world that follows this definition globally. We are referring to our 4 problems again. We've identified them. What is more, we've also worked through how these problems should be targeted, how they can be solved. This staffing question, the lack of pain relief, the lack of laws and standards, infrastructural issues, all of this. We covered all of these items. This is the rule. When you go to the authority, don't bring them the problems, bring them the solutions. Then what we do, look what's going to happen if you solve this. The pain relief is going to grow 20 times. And we have already calculated the numbers for the industry. If you want to produce that yourself, can you imagine how much the production grows? The number of doctors will grow. This is important. This is learning. This is teaching. Coming about the legislation, this is something the at least the Russian authorities, I'm not going to speak about the other countries, but the changes in legislation, this is pretty fearful, but we try to understand. For every block, you just need to advance this. This is a little adjustment that's necessary. There is nothing pretty dramatic, just tiny little points that you need to adjust. And we try to show that we are already very professional. We just need to, you just need to listen to us a little bit, and they will, you guys, authorities, you will get your thanks, your gratitude from the upper level authorities. So that's what we try to convince them of. We also tried to explain that there is no cross-functional interaction between the organizations, the divisions, the departments, and we tried to explain and show that palliative care is by itself, by nature, an interdisciplinary phenomenon. If we organize this, it's going to be inevitably easier and better for you to create those connections for the elderly, the in-house support, etc. We tried to show this beautiful picture and explain that we can change the level in the global atlas. We can be a decent member of the global community to reach from level 3 to level 4B, where we have palliative care integrated into the healthcare systems. 2017, again, this was quite an appeal to the Russian government. Then any authority member should see money. You know, when you want to develop something new, it's very expensive, but you're going to show that you can economize or save money on something. Everybody knows the problem of external lung ventilation systems. You know, if this is a person is in ICU, it's very expensive. And we tried to show how many people annually in this country need ICU support in terms of lungs ventilation. And these are not the people who will, you know, stand up at some point and then go and continue their normal, regular life. We tried to show that these patients will not be cured. These patients will stay for a long time until the end of their days. If they are inpatient, back in 2017, this was 28,000 people per day. Now it's about 150,000 rubles per day. This is how much it costs for a person to stay at home. In this at-home presence, we even calculated the 24/7 nurse available for this person. And the calculation and the saving is fantastic. Of course, you need to introduce a lot of money for the equipment, for the infrastructure and education. However, it's still, those calculations are highly important. But at the same time, you should not forget that us, the leaders, the NGO leaders, we know more and better what costs what. And these calculations, it's only us who can make those calculations. Nobody can do it better than us, because we understand what's being lost, what's being accumulated, what's being gained. Here, what we've calculated is an interesting thing. When a person doesn't get pain relief by a palliative care, they would either call ambulance or they would need to go to a hospital, because there they will do the pain relief. This is where we show an ambulance call. If you don't have a system, one call is 16,200. If you have palliative care, you don't need to call the ambulance. You just have a recipe, you just have the drugs, it's zero. If a person is inpatient, the ambulance takes them to the hospital. If they are at home, then no need to do that. How much an ICU presence costs, how much the hospice support costs. Again, there is this quite clear definition and difference in terms of money. How much all in all it costs to be under our supervision at home? It's one visit a doctor per 3 days. This cost per year per person is 177,000 versus 76,000 you calculate this per number of people and show the saving. This is not what we've calculated. We hired an agency that has spent quite a lot of time working on that. How much money the government loses for the fact that the relatives do not work their full-time jobs and take care of their sick relatives. And the sexy results that we have shown per year, looking at these results, I understand that in most cases, these results were achieved. In fact, we have this text, back at that time in Russia, again, I'm referring to what the government was interested in. Please search for what the government sees as a priority. Back at the time, we were very interested in the development of government leaders in regional governors. And so we've used the phrase, especially in the places, especially locally, especially in the field. This is something that is very relevant to the Russian authorities back at the time. The line we've used, something that can be probably translated as a friend in need is a friend indeed, or a help in need is a help indeed. So we tried to show this emotion that was, again, culturally relevant to the target audience. I want to just add that we did not find this national project accepted. Unfortunately, the government did not confirm this palliative care development as a national project. However, this work was extremely helpful because we managed to inform all levels of government about the problem and about the methods to solve it. And thanks to this work, we have received from the federal government a whole complex of measures that they have identified and implemented starting from 2017. First of all, those were orders at the level of the president of the Russian Federation to properly identify the term palliative care. Then we've been heard that the current definition doesn't match the approach of the World Health Organization. And in the result, we are shrinking this amount of support. We have also introduced the fact that this is multidisciplinary help, and we've placed that in the legislation. We've identified that this is the constant connection between social service providers, psychological support, relatives, work, etc. Another thing is that we formulated this priority, this project we've been developing. We understood that we got the order from the president to ensure the ones who were sick at home, so that they should be equipped with drugs and medications. This norm was put into the federal law and into the system of guarantees for healthcare to citizens. Apart from that, there was also an order given to the regional government to prep the programs for palliative care development. Back at that time, I didn't understand why we took this task on our shoulders to do the monitoring of healthcare programs. We do a lot of monitorings quite regularly, how this program is being implemented. But in fact, now we understand why we did that. If we don't take this function of monitoring, then any governmental institution, everybody across the world knows that the authorities, official authorities, the bureaucratic leaders, they're always very busy and always very tired, and they never want to take extra burden. And you always need to double check if these specific numbers are real or not, and you always need to provide the realistic information. And this gives us a chance, this order gives us a chance to annually make monitoring, identify those fake numbers, fake statistics, and always keep regional bodies, I would say, clearly energized and very cautious about those numbers. they know that the president will receive the real information, not in paper, but in the fields. This is a great impetus for development. This is a great drive for development for them.
Второй комплекс причин, по которым ВОЗ озвучивает как...
The second complex of numbers that, the second complex of reasons why we see the issues and the problems in development of palliative care by WHO is the problem of highly regulated pain relief. We don't have proper access for the population to pain relief, opioid-based pain relief. This is a beautiful information infographic map. When we were prepping this program, we understood that the International Committee of Drug Control is our ally in terms of availability of opioid-based relief, pain relief. The more available opioid-based pain relief is, the less reasons there are for illegal turnover for the pain relief, opioid-based pain relief. This beautiful map demonstrates what is the sufficiency and availability of opioid analgesics for different populations of different countries across the world. In multiple countries, the availability is 1,000 times higher than necessary. For example, in the Russian Federation or post-Soviet countries, this demand is extremely high. You don't even see these countries in the map. It's only 8% of the population is properly sufficiently provided with opioid-based analgesics. It was a great reason for a conversation with the governments because we started working on the availability of opioid-based pain relief. This was both legal work and normative work, as well as in media, and this was a lot of PR. I want you to hear every time at every slide one and the same idea. The interaction with the government structures that ensure the quality of life for our patients. It's not that we should say, we need this or our patients need that. We should search for what they need, where our interests cross over with the interests of stakeholders. Look, there are no countries. Our countries are not there. Our post-Soviet countries are not here. No authority, no bureaucrat would love that. They would want to be in this map. We're trying to work following and targeting their interest. We look almost like Nigeria or Uganda. And this is not very decent for the Russian bureaucrats. And this map is a big argument in terms of fear of opioid developments, against the opioid phobia, I would say. The problem that exists in the USA and Canada, they are so far away from us. You know, a lot of people say, oh, the United States, so many addicts, overdose. Yes, I understand. That's terrible. We don't want to be there. But it is so far from us. We have a couple of, centuries to reach this level. Apart from that, the International Committee controlling opioids in 2019 has made a research, 2018 they made a research. What reasons prevent the accessibility or hinder the availability of opioids? The yellow line is something that's relevant for everyone. It's been more than 100 countries questioned. The ministries of health were polled, civil organizations were questioned. The main reason was the lack of knowledge and preparation for the medical workers. Another big reason that was announced, it's of course, the fear of dependencies or addictions. This is one of the key reasons. There are some reasons with some terrible legislations or the fear of leakage or the fear of responsibility. These 38%, again, 38% find that it's the lack of knowledge. We sometimes, overestimate the importance of responsibility or the importance of legislation. So it's the lack of awareness first and foremost. But this is the poll that was done across the world. For us, one of the factors that we have been focused on, these are the legislative requirements, quite heavy legislative requirements. And that's what we've done in terms of changing the legislation. We have introduced quite a declarative norm that patients has a chance for pain relief, including the use of narcotic drugs. We have canceled the need for the return of the used ampules in the hospitals. We have prolonged the expiry date for the recipes that were for the prescriptions, for the narcotic drugs from 5 to 15 days. We've been analyzing how much 15 days are enough, and we understood that we're not going to prolong this term. 15 days is quite okay. It's an optimal number for the prescription. So when a patient receives this prescription, after that time, probably you should see a doctor again. That after that is usually, it's probably not relevant to prolong the prescription. But on the prescription, considering the Russian legislation, we can make the prescription for a longer period of time when the medical approach is already identified. For example, when the drugs are provided for a month. We have made it simpler for the receipts of the narcotic drugs so that the prescriptions could be done at the bed of a patient. Nobody apart from Moscow uses this norm. Yaroslav region, probably.
So the organizations that are connected to VERA Foundation can do this. We also cancelled the requirement to specifically dispose of the ampules. Now we can just dispose them in the general manner. And now actually one can store the medicines for 3 days in clinics. In the past, it was only 1 day. And now the patient can actually get the medicine, buy the medicine in any pharmacy, not only the pharmacy that is indicated in the prescription. That's a very important requirement, and that's a very important change for everybody who is present here. Because when it comes to some attachment to pharmacies, it actually exists. And people in less densely populated towns sometimes have to go to some large cities. So this process for them is far from being easy, and it needs to be changed. Another problem is the fear of persecution. We also worked with this when it comes to the changes to the legislation, as well as we also were raising awareness, and we used some specific cases. When it comes to criminal prosecution, according to the criminal code in Russia, a medical staff could be prosecuted and held liable even if there was some offense that happened because of lack of attention, regardless of the volume of the drug that was somehow lost. So in the past, if one ampule is somehow lost and is not taken into account or not accounted for, then this could be a criminal offense. For example, there was a case when a doctor from an ambulance just put his case in the street. So this is this yellow box with the medicines. So an ambulance doctor just put it in the street because he was helping a patient that needed help. And so there was one morphine ampule, and that person was held accountable according to the criminal law. So there was a long fight with the Ministry of Interior Affairs. They didn't want to ease this legislation. They didn't want to make the situation more comfortable, but we applied to the president multiple times, and finally, our doctors are now not held accountable if something happens because of the lack of attention, and there is no harm to the interests that are protected by law. In other words, like there is no harm to other people. Well, you know, this language, legal language is difficult. So the main idea is that if there is no bad intentions of coming from the medical stuff, then it is not persecuted. And this scary word, decriminalization, this is actually what happened. For example, if an ampule is broken, if an ampule is with morphine, it was in the professional dress of a doctor. And then a doctor was visiting a patient at home and somehow lost this ampule. So now this is not a criminal offense according to the Russian criminal code. And after the changes that were introduced to the criminal code, there were no legal cases. At the same time, we didn't only work with the legislation changes, but we also worked with enforcement, because both the criminal law and administrative code, they are very strict. At the same time, we worked with the population and with the media, because the state, the government is rigid. Nobody would change anything if there is no push coming from the outside, from the public. We got lucky. We managed to do this when Russia was still a more free country. And everybody who is watching us today can actually do this exercise, maybe except for Belarus. So you can talk to the media in your countries. What's important to understand is that nobody will change anything if you apply pressure. Pressure are the big, loud cases. You can take a small case. For example, the case of a gynecologist, Oleg Baskakov. So he lived somewhere in the Sverdlovsk region, or even further from that, 600 kilometers from Yekaterinburg. So Nastya went to investigate this case of a gynecologist, and Nastya made this small, tiny case of a gynecologist somewhere in Yekaterinburg visible to everybody. Nastya made it visible that the case wasn't fair at all. So the main idea is that we have to make it public. And so, for example, just a story about a fine equal to 200,000 rubles, when it gains attention, then it can actually be even streamed on the TV. Actually, the Children's Hospital, which is called the Lighthouse Charity Foundation, was fined for, well, and there were actually some reasons for this. So Oleg Baskakov, the gynecologist from Ekaterinburg, as well as Lighthouse Charity Foundation, they violated the rules on drugs control. So Oleg Baskakov took an ampule, and he injected a patient with the drug from this ampule. So the patient had to be sedated, and he used the ampule that wasn't actually intended for this purpose in that clinic. And so he could have um, ended up in prison. The Lighthouse Charity Foundation also violated the rules of the work with morphine. They had logs on the storage of morphine and opioids, but they didn't store it in a safe lock. And they didn't add the recent interventions that they did with this drug. So the violation happened, yes, it happened, but the fine had to be paid from the charity funds. Is it fair? No, it's not fair. And so there was indeed some pressure applied on the authorities. And so it seems to me that the pressure on the authorities was even heavier than the non-fairness of the fine. that was issued to the Lighthouse Charity Foundation. Ksenia, could we start the video about the pressure on the authorities in connection to the case with the Lighthouse Charity Foundation violation? Yes, so please stop sharing your screen and then I'll be able to screen the video. So we can barely hear Valia. She experienced severe pain. She was screaming every night because of the pain and she lost her voice. 17 sets of chemotherapy, but the tumor is still growing. Valia experiences more and more pain. This is when the morphine should be administered. But in all the hospices and clinics in Russia, we have this large pile of logs. Well, each ampule should be accounted for with the number, the name of the patient, the medical record, the series of the morphine, etc. Oncologist Mr. Ibragimov can't do anything about it because morphine is a drug, and so it should be very well protected. And so also the founder of the VERA Hospice Charity Fund just signs about it because it's very difficult actually to administer morphine. The ambulances around the whole Russia require from its employees and teams after each injection of a morphine, the team should come back to their base and they should withdraw the or write off this medicine. So instead of coming to the next patient, the ambulance team should have come back and write it off. So actually it takes hours of records, hours of registration. Well, sometimes one can just forget about it and then it is a criminal article in the criminal code about the drugs circulation. That happened with the Lighthouse Charity Foundation. We faced problems with our logs. Some logs weren't like notarized and they weren't formatted in the right manner. And so actually we were told that nobody can do the logs properly. The problem is not only about the checks and fines, but also about the availability of some medicines for children. If in this clinic we do have access to drugs, to narcotics, we can get this access in 30 minutes. But colleagues in palliative care that work locally, they are in absolutely different situation. And so we start the count of weeks and months for getting the good morphine. That's why quite often doctors don't want to do anything with the narcotics and drugs. For example, we have a person from St. Petersburg and she wanted to get morphine for her relative who was suffering. We couldn't get it anyhow officially through the clinic. We couldn't get the prescription for the morphine. The clinic, the local clinic, is afraid of prescribing morphine. At the same time, the patient is suffering. And the charity foundation can help with this. Sometimes palliative care teams can also do this. Right. Of course, we want to help this. And what about cities where there are no ambulances, special services, or hospices? Quite often, parents of children in pain call us. We start to investigate the cases, but quite often doctors are afraid of this. And this will last up until the pain relief will be associated with the drugs control. We need to simplify the drug circulation in hospices and in clinics. We have to fill everything in. Every nurse should know how to do it very properly. Like first two pages of the order is the list of normative legislative acts that we should know and which we should comply with. From the legislative point of view, we don't have this distinction between the drug control for non-medical use and drugs for medical use control. Up until this country recognizes that medical turnover of drugs has nothing to do with drug addiction and drugs problem, nothing will change. In the pediatric hospice Lighthouse Charity Foundation, the patient asks to help with the pain relief. She can't really control her pain. Now she's got morphine. Maybe the nurse forgotten just to register everything properly in the log because this patient was screaming because of pain. This is not dignity. This is suffering in pain that will not leave without morphine.
С Настей смотрели
Right, so we were watching this video together with Nastya, and we were actually surprised in a negative way by our own manipulation. It's understandable, actually, that to make this report, we had to work with journalists a lot. We helped with the text. We worked with the mother of this patient. We convinced her to participate on the video. And it's an intentional manipulation from our side. And this video was distributed among all the civil servants by the word of mouth. Right, and so I think that this video has a multiple effect because it's aimed not only at changing the turnover of drugs rules, because that happened in 2021, and all the changes to the legislation when it comes to drug circulation for medical use, all these changes were made, those that were possible. But at the same time, this is the video that draws attention to the issue, to the problem. It also changes the enforcement, because for the first time, courts actually cancelled this decision for the Lighthouse Charity Foundation. The court said, yes, the violations happened, but one cannot issue a fine equal to 200,000 rubles because of this. That was the first case when the government, the state, recognized that the volume, the size of the fine is not corresponding to the severity of the offense. So we wanted to draw attention to the problem in general in the country. Well, in Moscow, the pain relief for children problem is different. It's almost non-existent, but we touched upon St. Petersburg and some other constituencies of Russia, and we eased this enforcement, law enforcement, even though we don't have the case law in Russia, but still courts take cue from the previous cases when they make their decisions. And actually, there were no high-profile cases on this topic after that.
Сейчас, простите, мы еще раз переключалку тут.
So we need to once again
Ну, как?
be able to manage our presentation.
А куда мы? Сейчас.
Настя, это вверху, вот в верхней панели, где 17. Да.
Some technical issues. Right, now everything is okay. So, talking about what else we've done over this very short period of time. The International Committee also saw some problems with the control measures from or for the manufacturers. And over that period of time, thanks to the Moscow endocrine manufacturing site, this is the monopolist in Russia for the manufacturing of opioid analgesics, we enhanced the number of available medicines, opioid medicines, when it comes to dosage forms as well as the medicines themselves. So 17 of them are in the VED list, and well, patients can get these medicines for free within the palliative care. And additionally, thanks to the national project that we showed a bit earlier, we convinced the federal government to allocate almost 46 million USD to support the regions in purchasing medicines, drugs, narcotics for medical use, and creation of infrastructure for medical care, such as oxygenators, the artificial lung ventilators, as well as some other equipment for palliative care and for transfer of medical devices to use at home.
However, we implement the monitoring as mentioned earlier. What happens in the Russian Federation, we monitor all of this. And for the time being, we see that the most challenging issue that we cannot tackle at the moment in the country, it's the lack of knowledge and lack of proper preparation and training So despite we have so many different drugs and medications, 17 analgesics, 52 different forms and dosages. If we go to regions and if we see what happens in the procedural rooms, we'll have at max 4 types of drugs. It's important here to highlight that just a couple of years ago, there was nothing there available. This interaction at the level of, proper intellectual conversation with the government gave us the understanding what they're interested in. They're interested in producing their own drugs, not importing it from abroad. This gave us a chance to kickstart the production and change the legislation. And again, we are limited by the knowledge and understanding of the doctors. There are no limitations in the country at the moment so that a person would get a proper pain relief, not only in the end of their life, but across any different situations. There are no legislative, financial, or other limitations, just the head of a doctor, the brain of a doctor, the skill of a doctor. That's the limitation so far. What we have as a part of monitoring, we have Moscow doctors from different palliative centers. They look at the medical documentation of the patients. They do consiliums inpatient with, and we see that very often the drugs that are available are not being used. And there are several organizational limitations that are still there. For example, the permission for just one doctor in the region to prescribe this. It's the only one doctor that is able to prescribe the opioids like that. However, according to the legislation so far, any doctor can do that. And I think moving on, it's for you, Nuta. Yes, this triangle that you see, you all have seen it. The palliative care consists of available pain relief, when we have infrastructure, and when we have properly trained doctors. But without political will, nothing will move. In order to create this political will, we wanted to have a video that you've seen in the first place. What was our accent in this video? I've already shared with you. The political will may appear by itself if, for example, your political leader becomes a witness of a challenging personal situation like that. But I hope it will never happen to anyone. And I only hope that this happens by a conscious decision. My big ally, Mikhail Abizov, he's in the prison for many years, unfortunately. He has taught me this interaction between, to see between the lines, to understand what an authority wants, to see that with their eyes, to think with their mind. In the UK, I think it was said, if you want a palliative care, do not be afraid to dance with the devil. If you need palliative care, do not be scared of your next steps. If you have a certain trajectory in your head, then you will reach this point. Of course, you will find that you need to do a compromise, but you don't change your ultimate goal. Mikhail and I, we've spent lots of time together. I learned from him every minute. And what we've reached, it's his teaching. It's important to study those GR technologies, how you can impact and influence the local bureaucracies. These are cases that Anastasia has shared. These are the cases that have both changed the legislation. These are cases that have increased the awareness in the society, that changed the attitude of the society to the problem. If you boost them through PR and GR, you create a request, a demand for high quality high quality care. Do not be afraid to interact with nobody, no matter how high the top level authority is. Do not be afraid to speak online and live streaming in the top TV channels, in the top government bodies. Do not be scared. You probably know that I'm being very seriously blamed in collaboration with the Russian government, but I'm sure you mostly come from the countries where such kind of accusations are not there, because you understand what it all stands for. You should use the max of effort so that people who are your stakeholders hear you. You need to make a lot of communication so that they can see what's going on in the field. And you should never stop the communication when you've already achieved something. You have achieved something, finally something is done, and even the mini tiny little change, it it's good, but it doesn't mean that your stakeholder is irrelevant for you anymore. Continue being thankful, send them the pictures of the good results, share some very good stories, the achievements. For the authorities, we very often become the source of endless stress and shit, I would say. And we share what doesn't work, what doesn't happen nice, and we never share what's working. With any relationship, you have 4 yes and 1 no. For compliments, you do 1 criticism. Share what's good, give them a mic, welcome them to speak at your events, give them a reasonable chance to share that your achievements are also their achievements. And of course, speculate. Speculate. I'm sorry for this word, but speculate by the patients, just as you can see it here in the picture. A very heavy manipulation, a very cruel manipulation happened. Look, we've had this national priority project over palliative care. We've changed the legislation. We've had this definition. We've achieved our own results in this pain relief drug production. We've changed legislation for the drug prescription. The prescriptions are long term, they are being prescribed at the bed of a patient. But apart from lack of awareness and training of the doctors, some drugs may not be registered in Russia, but they are very necessary. From the Russian legislation perspective, they are illegal. And if these drugs appeared in Russia, a lot of people could just go in prison. Such a drug was Frisium. For instance, for kids in palliative care who have had multiple epileptic seizures. In the number of countries where you come from, Frisium is available. It's legal, luckily. And there is no cruel legislation like ours. But I want you to look at this case very carefully when it comes to this transition, so that this transition from 3A into 4A, for this to happen, so that you pass by 3A, 3B, and 4A, you need to have the societal request, the societal demand for the proper support. The society should understand what's good and what's not. This is very complex work that should be done very quickly, de facto within 2 days. We needed to make our kids and our parents and the authorities, we wanted to make them our allies. And we should have the doctors who face this problem. So we turned this event into a GR. The mother was arrested, and we tried to showcase this situation. The politicians have used this case, for example, Miss Batalina or Fanaryov, for example, Mr. Fanaryov. They have become the heroes of the story because they found a resolution. World Health Organization say that one of the problems is the availability of psychedelic and narcotic drugs for the palliative care. And this story is much brighter than the previous video, when we just not only released mother from the criminal responsibility. The operative officers noticed her on the internet. She thought she was selling this drug to another mom like that. She was selling that to the operative policeman in disguise. And it's important that as a result, we not only released her from the arrest and from the criminal responsibility, we have achieved, first of all, simplified import of those narcotic drugs in Russia. We have achieved that Russia had some responsible body at the level of the Ministry of Health, responsible for every child to be provided with the specific drug. And in a couple of years, we have started the production of our own drug in Russia. And the problem has almost disappeared. In 2021, we have been producing this one. We have less than 10 minutes available, so let's move to see this video. And probably it's about 2 minutes, I believe. I think it was a pretty powerful manipulation, I would say. But it worked pretty fantastically. May I correct? If we don't have the sound, sometimes it doesn't work well, unfortunately. Would you be able to comment on that? No sound on, I'm sorry. Just give me a second. I'm so sorry. We have a link to YouTube to see this video. We're gonna share it in the chat, which we have here in Zoom. Your mic is off, Nuta. Please share the video in the Zoom chat. It's already there. We'll switch it on and you will move it to the start. Just a second. We're gonna start both and hopefully it works. From the start? Hold on. Hold on. Don't press the button. Nastya will tell you. Hold on. You need to... No. I'm gonna do it differently. The link is in the Zoom chat. Just a second, I'm gonna PM it to you.
У кого-то есть вопросы,
If you guys have questions, if you have accumulated some questions, you can share them in the chat using this momentary pause. Whenever you're ready. Fantastic. 3 different cities are launching one and the same video at the same time.
Можем запускать.
We can start. 1, 2, 3. Okay. No sound. I'm sorry, Anastasia, it doesn't catch the sound. No. Unfortunately. Can we watch it with no sound? Yes, I'll just make a comment. Okay. When this mom was arrested, we made a request to the Ministry of Health. The Minister of Health has said that there are just 7 kids like that who need a drug like that. And we have immediately reached out to the mothers.
Заработало, что ли, звук?
Да.
18, 19, 20, 21, 22, 23, 24, 25, 26, 27. At the minimal count, there are more than 23,000 people suffering from different epileptic syndromes, and they need the drugs that are not registered in Russia. There are much more than 7. I don't know if you have heard, but all the mothers have agreed to record several seconds of this video. And of course, we managed to go through this work. We've video shot, we've edited, and we started spreading this across the country through different bloggers. The video has become super popular, and the government had no other way but to react. I will also share that there was a bit different country back before the 24th of February 2020. This is the most important thing that I wanted to share with you. The solutions are always, the decisions, I'm sorry, are always made by people. It's not the ministry itself, but it's the specific people. And in order to convince people, you need to talk to them. And the word was always that you start with. We were told that you should communicate with the others like the way you want to be communicated with. But in fact, you should flip the formula and say, you should speak to people the way they want to be spoken to, the way they want to be communicated with. And if you want to achieve your result, you always need to understand why you're doing this. If you understand why you're doing what you're doing, then the other people will follow, because this very important question, why or what for, this is a very clear message. For example, this video with the different moms, it makes it very understandable that you work so that it never happens again. Any person wants to be an ally to such changes. They want to make a part in the change of the law, rewrite the text, do some complicated procedures that will be in the line of other procedures. This is all very complicated, but people all want to co-participate. They want to be the party to that process. They want to be the collaborators to this process. This is a huge motivation for every person. And I really want all of you to understand that all your stakeholders are the collaborators. They need to be co-stakeholders. They need to be your friends, allies, and become their friends so that this collaboration will be better. But this is what I'm going to skip because of time.
So you will see the photos later. Here, at the end, you can see what you can do when there is no legislation, when you're not at the level of 3A or 4B. You still can work with volunteers. Well, as we already mentioned today, we can't add days to the life, but we can make the life better. So in the left, you can see a woman with a special plaster with a morphine. In the middle, you have a photo shoot. You see the photo shoot. This is a woman that wanted to have a photo shoot in the style of Coco Chanel. She also gets morphine. And also in the right, we can see the child with a tracheostoma. We can add to the everyday of these people. These are the volunteers, absolutely different ones, musicians, pets, dogs, confectioners, chefs. There was a volunteer who came up with an idea of the happiness card. This card distributes among patients what they don't get on a daily basis in terms of products and nice food. This is a New Year celebration. Well, if one understands that somebody cannot really live to the New Year, then the New Year can be celebrated earlier. These are volunteers that help at the events. These are fundraisers. Beeline company started to fine their employees for being late. And so Beeline said that all the fines that they'll collect because of employees are late, they will be given to the hospice charity fund VERA. Uh, you also have heard about the campaign flowers or children instead of flowers. So the main conclusion here is that if you want to live a happy life, tied to a goal, not to people or things. This is the quote from Albert Einstein. And so later you'll be able to see the appendix in our slides, and those are systematic responses to the questions that we continuously get from medical professionals and civil servants. Such questions as what are the difference between the means of palliative care and palliative care as it is, what groups of patients we help and what groups of patients we don't cover. Another question, for example, do we help patients in remission? Do we help disabled people? Do we help elderly people? And also they ask, for example, palliative care, it's the care only for people who are going to die. No, not only. Palliative care, is it only about pain relief or not? So basically, all the frequently asked questions that we get, we provide simple responses to those questions. So I think it's a very important appendix. You will be able to see it in our slides. So thank you very much. We are sharp on time. 2 hours we spent together. If you have time to ask some questions, then you can write them in the chat and we'll provide answers. Actually, we've got an answer, the question in the chat. Thank you, Nuta, and thank you, Anastasia. In any case, we not only publish the recordings of our webinars after each of the events, but we also post the minutes after every event. So if anybody had to run, these people will also get the information. So we've got a question in the chat. How do you calculate the volume of available opioids when it comes to the demand for pain relief? Is this about the number of opioids that were purchased by medical facilities or not? The answer is, it depends on the country a lot, on the system in that country. It depends on how your system works. Because in Russia, we have our own manufacturing facility, and this facility works depending on the demand from the regions. So all the regions accumulate their demand. For example, they say, we need this quantity for the next year. Then this quantity is produced, is manufactured. Then federal government allocates finance to the region to allow the region to buy what they asked for and what was manufactured for them. So the region has to buy it, purchase it, and has to use it. And here we have a problem. For example, the region can ask. Okay, so we have some specification of the question. So the question was about the slide with a world map where in the US and Canada, the availability of the drugs is about 3,000%, and in the Russian Federation it's 8%. So yes, we have statistics on the available number of medicines. It is divided among all the population over the course of 365 days. And so I can't really reproduce the formula of calculation now, but this is the average daily dose. It's the same all over the world. So you just need to find this figure and recalculate it for the population in some specific country. So the percentage, right, so the percentage is how much is available. So to respond to your question, what does this mean, the available quantity? In every country, the Committee on the Drug Control calculated, proceeding from the daily dose of drugs, the portion of the medical opioid analgesics. And then every country that is in the system, that is in the Convention for the Drugs Control, it has to also report to this body on the volumes of drugs that were produced and used. So we every year report to the Ministry of Industry and Commerce the number of or the volume of the drugs that we consumed for medical use. Right, but one needs to understand that countries can provide fake information, right? Because, well, some people collect data from the medical organizations, and some people actually get this data from pharmacies. And the data that is provided by the pharmacy, it is not the data actually that was, those are not the volumes that were actually injected and used. Okay, thank you very much for your question. You can also voice your questions because we can use Russian or English, we'll translate it. It doesn't matter. Or after the webinar, you can also write your questions in the chat, paste group chat. For those of you who don't know about our group chat, my colleagues will now publish the link to the Google form, and this form will help you to join our group chat later. So you can ask your questions in our group chat after the webinar. So I don't see any questions coming now. So Nuta, Anastasia, thank you very much. And I would like to continue with our announcements. In the end, you had a large block on what can be done now. It was about volunteering. We already had a webinar on volunteering in hospices that was in August, but we'd like to continue this topic because a lot of colleagues in different countries have this experience. I remember colleagues from Moldova shared their experience, colleagues from other countries did the same. So colleagues, if you have anything to ask about or share in connection to volunteering, please write us and then we will continue. Also, the same goes about fundraising. How to talk to potential donors, how to do fundraising. So all the announcements will be published. You can see them now in the chat. It's important to talk about what's important for you. We will just respond to your demand. And about the questions connected to medical care and pain relief, we got the answers. Thank you very much to those who commented and voted. So for November and December, we are getting the program ready for you. So we will organize the events on medical care. And last November, we organized a large webinar and we had a large program. And so we continue to develop this program this year as well. So thank you, dear colleagues. Thank you for the translation. And so we would like to enhance the languages that we use. Thank you, PASTE team, and thank you all our guests today. And I see the hearts flying. I hope, Nuta and Anastasia, you see the hearts in our webinar. So have a good day. And I would like to wish everybody peace and calm. Thank you.